The three injections we'll be demonstrating are the anterior superior alveolar, the middle superior alveolar, and the posterior superior alveolar. The first injection we're going to be demonstrating is the anterior superior alveolar. With your non-dominant hand, press the thumb downward near the nose to create some distraction while the lip is being gently pinched. The insertion point is into the vestibular area at the height of the mucobuccal fold, just mesial to the canine and advancing to the apex of the canine. Align the barrel of the syringe parallel to the long axis of the tooth, following the contour of the maxilla. Advance to a maximum depth of 1/4 to 1/2 inch. After a negative aspiration, deposit approximately 1/2 of a cartridge of the anesthetic solution with multiple aspirations. The next injection we're going to demonstrate is the middle superior alveolar. To distract, the thumb of the non-dominant hand is resting slightly forward of the zygomatic arch. Again, with downward pressure for distraction, the lip is gently lifted and pinched slightly. The insertion site is over the second premolar in the vestibular area. To achieve the proper angulation, keep the syringe parallel to the long axis of the tooth, following the contour of the maxilla. Your deposition site is well above the apex of the premolars. The needle probably will penetrate from 1/4 to 1/2 inch into the tissue. When you've reached maximum depth after a negative aspiration, deposit approximately 1/2 cartridge of anesthetic with multiple aspirations. The last maxillary injection we'll be demonstrating is the posterior superior alveolar block. Remember, this is a deeper injection and the anesthetic is being placed close to the nerve trunk. With the PSA injection, the patient's mouth should be partially closed. You should have your thumb resting on the zygomatic process, pressing slightly for distraction. And then your index finger should be placed in the vestibule to palpate the zygomatic arch. This is an essential landmark to discover. The tip of your finger should be slightly distal to the zygomatic arch. When your hand is in this position, thumb on the zygoma and the index finger in the vestibule, and the fingertip distal to the zygomatic arch, your finger is actually pointing to the site to which you are going to direct your needle. The needle penetration site is into the tissues at the height of the mucobuccal fold, at the apex of the second molar, distal to the zygomatic process of the maxilla, inserting upward and inward to conform to the tuberosity. The angle of needle insertion is upward at a 45-degree angle to the occlusal plane, inward behind the maxillary tuberosity at a 45-degree angle to the mid-sagittal plane, then backward at a 45-degree angle to the long axis of the maxillary second molar. About 3/4 of an inch is the depth of this injection. Once you're there, obtain a negative aspiration in 2 planes and then start depositing the anesthetic. 1/2 to 3/4 of a carpule will be necessary with multiple aspirations. The injections we will be demonstrating will be the inferior alveolar block, the lingual block, the long buccal block, and the mental block. The distraction points for the inferior alveolar and lingual will be with the thumb on the coronoid notch and the fingers of the hand resting on the angle and posterior border of the ramus. Have the patient open widely and palpate the greatest depth of the coronoid notch and move your thumb laterally to make the tissue taut. A lateral movement of the thumb until you reach the external oblique ridge indicates the end point of the thumb positioning. Remember that your penetration site is determined by the greatest depth of the coronoid notch, about 6 to 10 millimeters above the occlusal plane, and is slightly lateral to the pterygomandibular raphe, into the apex of the retromolar triangle. The barrel of the syringe is parallel to the occlusal plane and will be positioned at the corner of the mouth and over the premolars on the opposite side. With this injection, you should meet resistance at your maximum depth of 1 to 1 1/4 inches, which confirms the deposition site near the medial aspect of the ramus. Once you've contacted the ramus, you must back off 1 millimeter before you aspirate and deposit, so that the needle is not tightly against the periosteum. Obtain negative aspirations in 2 planes and start depositing about 3/4 of a cartridge of anesthetic with multiple aspirations. When you have completed the IA, you will want to anesthetize the lingual nerve, which is about half the distance of the injection site on this same track. In order to anesthetize the lingual nerve, all you'll do is withdraw the needle about halfway. After a negative aspiration at that point, deposit about 1/8 of a carpule of your anesthetic, and this will then block the lingual nerve. So now that we've gotten the lingual and mandibular nerve anesthetized, the next injection to complete the mandibular block is the long buccal nerve block. Withdraw the needle from the injection site. Reposition your thumb more laterally to the outer limit of the coronoid notch, keeping the tissue taut. Insert the needle into the tissue on the ascending part of the ramus, distal to the last molar, parallel to the occlusal plane, and lateral to the buccal cusps. This is a very shallow injection, and you'll meet resistance quickly. After a negative aspiration, another 1/8 of a cartridge of anesthetic is deposited here, and that should complete the full carpule that you started with. So you have used the entire cartridge to give these 3 block injections for the mandibular quadrant. For the mental injection, generally the operator is sitting above and behind the patient in about the 11 o'clock position, grasping the lip with the thumb and fingers and retracting so they can visualize the vestibular area and the premolar region. Pull out the lip with the thumb and first finger, pinching it slightly for distraction. The penetration site should be into the vestibular area in the region of the mental foramen, approximately at the apex of the second premolar. After locating the insertion point, align the syringe vertically with the patient's cheek to approach the penetration site, advancing the needle with a slight distal to mesial angle to accommodate the slope of the foramen. The depth of penetration is about 1/4 of an inch. After a negative aspiration, deposit about 1/4 to 1/3 of a cartridge slowly with multiple aspirations. The next injections we're going to demonstrate are the palatal injections. There are 2 principal injections, the greater palatine and the nasopalatine. The technique for giving these injections is to have direct vision into the site of penetration. So having the patient in a supine or prone position is important. Have them open wide, turning their head one way or the other so you can visualize the area. The first injection we're demonstrating is the greater palatine. The insertion point for the greater palatine is found by visualizing a line approximately halfway down from the second molar, from the attached gingiva toward the midline. If you palpate there, you'll find a soft, spongy tissue area. Notice the position of the cotton swab. You will be applying your pressure anesthesia with the cotton end of a swab after you've applied topical for a period of time. You'll place the bevel of your needle flat against the tissue, next to the pressure point or as close as you can get it, and hold the needle in such a way that you don't penetrate the tissue, but exert pressure on the plunger, so you're dispensing a small quantity of anesthetic over several seconds. As that takes effect, slowly let the needle penetrate into the tissue. This is a shallow injection, and with the 1/4 inch depth, you will meet resistance quickly. After a negative aspiration, very slowly deposit approximately 1/4 of a carpule with multiple aspirations. The nasopalatine is done in a similar manner. The insertion point for the nasopalatine is at the junction of the incisive papilla and palatal tissue on one side or the other of the incisive papilla. After you apply your topical to the penetration site, again with a cotton swab, exert firm pressure to cause some pressure anesthesia, laying the bevel of your needle as close to the pressure point as possible. Do not allow the needle to penetrate the tissue yet, holding a positive pressure on here so you're dispensing a drop or two at a time over several seconds. Then slowly letting the needle slide into the tissue until you've met resistance at a depth of about 1/4 of an inch. After negative aspiration, very slowly deposit 1/4 of a carpule or less with aspirations.